so today we are going to be doing a lap chole. So the patient has already been prepped, the drape has been placed, I've already thrown my cords off, and I've got a Raytech up here ready to go. So the first thing that your surgeon's going to do is make an incision on the belly button. So you are going to pass up the knife and the incision underneath the belly button is made. Then you're going to hand up a 10 millimeter trocar. This trocar is inserted into that incision. After this trocar has been inserted, the surgeon will then take and inflate the belly. So the anatomy is a lot easier to see. After the belly has been inflated, the surgeon is then going to take the scope. It's a 0-degree scope, and it's going to be inserted into that trocar. The scope is then used to do an exploratory lap, and they're going to look inside of the abdomen and make sure everything looks okay. And then next they are going to find out where they can put the next trocars. So the trocar that is going to be placed next is the subxiphoid trocar, and it's going to go up here on the upper left quadrant of the abdomen. So the knife is handed back up, and the surgeon is going to make that incision. After that incision is made, a 5 millimeter trocar is then placed. The knife is handed back up, and the next two trocars are going to be placed on the right anterior axillary. So those two incisions are then made, and then two more 5 millimeter trocars are inserted. The doctor is then handed a locking grasper, and it is inserted into that port. They then will find the fundus of the gallbladder, and they will distract that until the hilum is then seen. After the hilum is visualized, the doctor will then separate the cystic duct and the cystic artery. And after that is done, the doctor is then going to want the hemoclips. So the hemoclips are then placed, and there is going to be 3 on each, on the cystic duct and the cystic artery. There's 3 placed because you want 2 on the part that is going to be staying inside the body, and then you're going to have 1 for that is closest to the gallbladder that is going to come out along with the gallbladder. So you're going to place 3 on each. After that, you are going to hand up some scissors that the doctor is then going to insert and going to clip in between the hemoclips. Like I said, there's going to be 2 on one side and 1 on the other. After that, the first assist has their grasper, and they are holding on to the gallbladder. And they are holding on to the gallbladder with 1 grasper, and they are holding the liver up with the other grasper. At this point, the doctor, depending on the doctor, they could use the doctors that I mostly scrub with, they use J-hooks. So the J-hook is then given to the doctor, and it is inserted, and it's kind of like a bovie, and they are going to go in and kind of bovie the gallbladder away from the liver. So after the gallbladder is separated from the liver, the doctor is then going to want the bag. So after the gallbladder is separated from the liver, the surgeon is then going to want a different scope size so that they can take the gallbladder out. The scope that is already inserted, they are going to take that out, and they are going to swap it with a 5 millimeter scope. And this scope is then inserted on their left side, the trocar on their left side. And then the bag is handed up. And the reason why they do this is because the bag cannot go into the 5 millimeter trocar. The bag can only go into the 10 millimeter trocar. So they'll put the bag into the 10mm trocar, and the first assist will have their graspers and place the gallbladder into the bag. And then they are going to close the bag after, and they are going to pull the gallbladder out. And then the gallbladder is then given to the surgical tech, who then passes that off to the nurse to get that sent down to pathology. After the gallbladder is out and given to the surgical tech, the surgeon might want to look around the abdomen again to make sure that there's no bleeders or anything. And after they are satisfied, they will take the scope out, and then they will then take out all the trocars. So after everything is taken out, after all the trocars and everything are taken out, then you are going to start closing. And at this point, the surgical tech is then going to count their sharps and their sponges. They don't have to count all their instruments because it did not turn into an open. So after everything is closed, they are then going to take a wet and a dry lap, and they are going to take the wet one and clean off any blood or anything. And then they're going to take the dry one and just kind of dry off the stomach. Then Dermabond is then placed onto the incisions, and depending on the surgeon, they might want to put some kind of dressing over it, but mostly the surgeons that I worked with, the one particular surgeon that I worked with, did not put anything over the Dermabond.